So basically, when we're looking at doing a mobilization for the thoracic spine, we can do some side bending from below in order to close things down by putting a pillow underneath here. You can also do that with some of your unilateral manipulations. When you do that, you can check and see it. Does that help me with how they're shifting or not? Does that close? If I have a lack of closing on this side, if they're shifted and they're open and they can't close, will that help me guide them in their neuromuscular reeducation? Otherwise, you're going to find your level of hypertonus, and then you're going to try to get on the transverse process, use a key grip, and try to close that side down. So what you're doing, instead of bringing the top vertebra down, you're bringing the bottom vertebra up, which is relative closing, just like we did in the cervical spine. So we can cross his arms. I'll find my level of hypertonus, and the whole reason why I'm doing this is I feel that he's shifted here, and I think articularly where the hypertonus is, that I want to get him to close on that side. So I'll do a key grip, and because he's shifted here, I'll shift him this way, and I'll bring him into extension. And I'll take this hand and push down, but don't let me push you down. So see how I get him to activate his extensors. And relax, and then I shift and extend. I can use the key grip. I can use my hypothenar eminence under the transverse process on that side. The big thing is that I'm going to do a little bit of a shift and a little bit of an extension. And then I can also take a nice breath in and out, just to see if that relaxes that area as well. And then I continue with that shift and closing. So I can use breathing and I can use extension in order to do it. Now, if I'm doing flexion on the other side, I would still keep the pillow under here. And so now the assumption is, okay, I need to get him to close this way. That didn't make a difference, so I need to get him to open on this side. So to get a better hand placement, I'll go over to his other side. My hand is still in the front here, but I'll bias some opening with the translation. I'll find the hypertonus, and now I'm on the top segment, pushing up. So then I'll push him back, and don't let me push you back, so he'll go into a little bit of flexion and relax. But this is predicated on a ring shift, and we're using this and breathing. Take a nice breath in and out. And we'll see if we can do some sustained holding there. We're not oscillating. You could do some mobilizations with movement if you wanted to see if that was going to help. You could do that on either side. You can use breathing, and then you can see, can we retest that rotation afterwards and see if that makes a difference? Can we retest the active arm raise, see if that makes a difference? Can we check their function if that makes a difference? If it does, okay, remember my hands here and remember how you breathed. I'm going to have you do that, and then you give them the exercise, which is close to something that they can do. So our assumption is that there was a driver where they needed to close on one side or open on the other. We're doing a direct neuromuscular reed to see if we can impact it, and we're retesting. If that doesn't work, we could manipulate, or we could do some myofascial work. At the end of the day, after all of that, we would still come back to a technique like this for neuromuscular reeducation, and then retest them. They're stronger, match it to something functional, purposeful, and meaningful that they will do.